the Society of Interventional Radiology in Saudi Arabia. I would like to thank everyone, and I would like to thank all healthcare workers for being solid and for holding up during COVID. This is our first webinar for the society, and we're pleased to have really good cases here to show. As a start, we would like to start with the workflow in IR during COVID-19. I would like to thank all the speakers for putting things together in a short period of time. And I would also like to thank the participants and attendees. So with that, I mean, we can, just get to know people. Basically, our program is going to start after in 10 minutes or so. We're just going to get people together. We got a little bit earlier to leave some time for questions. And what we're going to start with is the SIRS position, or the SIR Society, or the Saudi Interventional Radiology Society position statement. Then we're going to go after that with Dr. Majd Ashur. And then we're going to go with SVC rupture during reconstruction of a chronic venous occlusion talk by Dr. Haroon. And then ureteroarterial fistula bleeding during catheter exchange with Dr. Yusuf Zahrani from National Guard Hospital. Then management of type 1 indolic complication by Dr. Nasser Al-Gharim, and SFA occlusion by Dr. Bandar Al-Dhafiri, recanalization of an SFA unusual case by Dr. Saad Al-Qahtani, and endovascular Warren shunt by Dr. Arabi. And then lastly, Dr. Salim Bayounis with percutaneous treatment of an aneurysmal bone cyst. And then we're going to conclude. So hopefully it would be an interesting session. What I would like from all of you is please, please, please use your name as the way you are signed in the program, or as it is exactly at the Saudi Commission for Health Sciences, because this is how we're going to know how to add your CME. Many questions came out as how many CMEs for this activity. It's on the flyer. It's actually 2 CME hours, but you have to sign in now and stick around until the end of this session to be able to look at the names and be able to give you your CME. We would like to also again mention that please, if you use like a nickname or a mobile number or something to kind of log in again with your full name so we can match the names and we can give you your CME. The other thing is you can ask questions in the QA. After each talk, it's going to be like 7 to 8 minutes, and then we're going to have 2 minutes for questions. So feel free to write them in the QA, and then we're going to select 1 or 2 questions as time allows, and then tell the speaker and answer those questions, then move to the next talk. With that, we can start with Dr. Majd Ashur. He is an attending interventional radiologist, one of the seniors at King Faisal Specialist Hospital, Jeddah, and he is the president of the Saudi Interventional Radiology Society. So welcome, Dr. Majd Ashur, and thank you so much. And he's going to give us the talk about the IR workflow during COVID. Please proceed.
Thank you, Dr. Al-Mamoun, for organizing this in a very short time. Also, I'd like to thank all the speakers that also accepted our invitation in a very short time. I think I will take this first to congratulate all of us for Ramadan Kareem. Kul aam wa bkhair. I think tomorrow is the first day of Ramadan, inshallah. Also, maybe we'll take this opportunity because this is one night of Ramadan to pray for all our patients and to hope for all of them to have a good health and recover very fast without any complications. And also we pray to Allah that all of us remain protected and healthy. Now, I'm gonna just share with you the presentation. I think I will start by saying we in the Kingdom of Saudi Arabia are very grateful to our government for the very early start of precautionary measurement that they took. And now we can witness this now. The disease is limited in Saudi Arabia compared to many, many developed countries around the world. And now it's almost 8 weeks since the first case was reported in Saudi Arabia. And alhamdulillah, still our numbers of infected patients are a smaller scale compared to others. So it's definitely whatever the government took care is functioning very well. Now, just briefly to remember that COVID, of course, started from China and Wuhan, and was the first reported case was in December 31st. And the Ministry of Health in Saudi Arabia took the lead with lots of other different government sectors in the kingdom, starting the precautionary measurements. That was started actually very early in January 21st. And the first case was reported in Saudi Arabia on March 2nd, as for a patient not coming from China, actually coming from Iran. And then the WHO declared that COVID-19 is a pandemic on March 11th. So you can see the sequences of events with these times very quickly. So what we learned so far is that COVID-19 is very highly contagious, very highly communicable. So within 3 months, it spread throughout the entire world almost. And we as a healthcare providers, we are not immune from this, of course. We know now from experiences mostly from China and Italy, significant physical and mental exhaustion they suffered. And also reports mostly in Italy, 20% of the healthcare workers were infected with the virus. And definitely there are deaths reported among healthcare workers, although we don't know the actual numbers. Now, vascular intervention radiology staff, whether technologists, nurses, radiologists, or whoever is working there, we are also prone to at a risk for exposure. We are also might be a source of spreading this to our colleagues or patients that we treat. And why also peculiar vascular intervention radiology? Because we cover a wide spectrum of diseases, pathologies, from head to toes. We deal with emergency and elective procedures. We do a lot of walk-in outpatient procedures. We do day procedures and inpatient procedures. So this is a variety of cases and patients we might see. We interconnect with lots of departments in the organization. And also we work within the radiology department where diagnostic imaging for COVID patients, particularly the area of CT and maybe MRI, that the patient may come. So the risk is also higher there. So we published our statement, and it's actually, you can see it in details in our website, search.org.sa, and also to be also in the Arab Journal of Interventional Radiology. You can refer to these two sites that look for the details of the recommendations. Now, when we looked and we looked at many aspects that we want to look into and to come up with some strategic planning. We looked at the hospital, of course, readiness itself and what are the regulations there. We looked at other lots of functional and physical places, the patient care areas, the patient flow, healthcare workers, visitors, supply, and the procedures itself, as well as the room where we do the procedures. So overall, in order for us to come up with the strategies, we looked into 4 different things. First is that we want to prevent. So prevent us from acquiring the infections as healthcare workers. And then also to protect. If we had to contact a patient or treat a patient, how to protect ourselves. And what do we do with the flow of the patients that's running in the organization? And also, which is very important, we need to confine these patients. So we don't want these patients to go everywhere and infect other people. So this is our strategies. Look at 4 important factors. Now, to summarize it is that in order to prevent us and our colleagues or the patient from infection, first of all of us, we have to understand and learn and follow the guidelines from Ministry of Health, from the CDC, from the hospital guidelines. To standard recommendations about how this patient is screened and what are the criteria for a patient to be labeled when the patients need to be screened, and what to do with it. This is very important for us to understand. So this is the knowledge that we have to learn. And of course, to prevent, I think the most important thing is hand hygiene, as well as social distancing. And this is applicable everywhere, whether inside the hospital or outside the hospital. And in order for us to protect ourselves, if you, for God's sake, we had to do a procedure in a patient that is COVID positive, like any other patients who have some kind of droplet infections or airborne infections. Now, what is requested from every single healthcare individuals, particularly our interventional radiology staff, is to know very well the personal protective equipment. What is required, what is needed, how to don, how to doff. It is extremely important to follow the expected guidelines of donning and doffing exactly. And also to have the N95 mask fitting, because this is very important in order for us to protect ourselves. What else also then we looked into how do we organize our workflow? And what the society recommends, of course, is that we move our outpatient from a physical regular clinics to virtual clinics. So by calling the patients by phone and documenting that. So we did not stop, or we should not stop the clinics, but we should also look into how do we communicate with the patients. We might just automatically need to reschedule some patients that they don't have significant issues if we know them. Otherwise, we should communicate with the patients and call them. And we recommend also that our patient care or business meeting should go to a video teleconference. Now, what is really important is that in order for us, again, to organize and protect ourselves is to create separate groups. So we divide ourselves into smaller groups from radiologists, technologists, and nurses, in order that if, for God's sake, a group get infected or contact a patient or to a positive person, then not the whole team will be quarantined. So at least we'll have a second or a third team that they can function independently. So this is really important. So this is from the beginning, we should start doing this. Also, in order for us to organize our work, we have to prioritize patients and procedures. And I'm going to go into details later on about this issue. And also to make sure that we have a secure supply, not only for the materials that we use in interventional radiology, but also for all our physical, for our personal protective equipment. So make sure that we have enough supply and we utilize it properly, because this is crucial. And the last point we touch into confining is it means that if there's a patient and we need to make sure that we don't spread infection from that patient to elsewhere. So confine the disease, confine the patient. So try to do as much as possible bedside procedures, and try not to bring them to the angio suite or procedure rooms in the department or in the section of interventional radiology. And if we have to do interventional procedures, or we have to bring the patient to do a fluoroscopy or something, it is suggested that if available, negative pressure room should be utilized. Although I know in majority of the departments are not, but as much as possible, we do that. Otherwise, if we have to do it, then we have to make sure that we don't use that room, and we do the proper equipment decontamination process afterward. And the hospital, infectious control, as well as biomedical engineering, they know exactly what process and steps needs to be taken. Now, the Saudi Patient Safety Center, they requested us actually from the second week, or maybe the end of first week, to go and try to put a list for prioritization of the procedures. And so they recommended 4 priorities. So priority 1 is an urgent kind of emergency procedure that requires immediately, but should be done within 24 hours. And priority 2 is for an urgent kind of procedures that can wait for within next 7 days. And priority 3 is for non-urgent, which is interventions required within 30 days. And a routine, which can be done after 30 days. So what we do recommend definitely is that we proceed with performing priority 1 and 2 groups, and definitely reschedule the patients in group 4 and make sure that we keep track of them through our logbook. And for the group 3, what we recommend is to look based upon the cases. There are some exams that needs to be done, and other exams can be also deferred to a later stage. So what we did is that we put the list in according to disease categories. So by diseases that we treat: arterial, venous, oncology, body imaging, non-vascular, and also neuro. But also we put the list by priorities. And I'm not going to go into each one of these, of course. You can refer to the paper. But so these are priority ones where things needs to be done immediately, like priority 2 also needs to be done. For priority 3, as I said, there are some cases that, based upon the case we need to discuss, should be done. Some type of oncology patients, sometimes you have to do them because you cannot defer them further. I think what is really needed from us now, we did set this, we wrote this recommendations about almost 3 weeks after the very first case of reported case in Saudi Arabia. And now it's almost a month past since we did our recommendations. And we need, of course, to issue some updates. Now, we need to look into what can we learn from the past 1 month.
2 minutes, Dr. Majid.
Yeah, okay, yes. The complications, what is relevant to us, what is the common side procedures that COVID patients require, and how to deal with the procedure under GA or aerosols. Looked into literature, and the complications that could be relevant to us is acute renal injury that might require some insertion of dialysis catheter. And of course, there have been reports of some thrombotic diseases, although none that required intervention so far was reported. Looking again, what was the commonest by far relates to specifically to COVID was mainly vascular lines and dialysis access. I would just want to emphasize on just one point that we did not touch, that using a powered air profiling respirator, this is it's now required for us if we're going to deal directly with a patient who's COVID positive or patient under a kind of aerosol generating procedures, like in a patient with tracheostomies that we're doing something in the trachea. I can now open the discussion. Okay, we can open the floor for discussion now if somebody has a question or something.
Thank you, Dr. Majid Ashur, for this informative update. So I'd like just to address a few of the questions that have been asked. Let me just share my screen quickly just to kind of show you the schedule again. And then I'll address the few questions that we have. So this is the program just for everyone to kind of look at. Again, if you kind of missed it. But basically, we had just questions not on COVID itself, but like some other questions on the hours. It's 2 hours, as we said, and the registration is through the link. So anyone who went through the link, you will be asked about the number of the Saudi Commission, and then you can go directly to the talk or to the program. There isn't any link here between the program and your name, so you have to put your name properly to be able to add your hours. When is the hours? We don't know. It depends on the Saudi Commission, and there's no certificate for the activity. But as far as the talk itself, I'm not seeing any question regarding the talk. So I think we will move to the next session, which is Dr. Ahmed Haroon, SVC rupture during revascularization or reconstruction of a chronic venous occlusion. So go ahead, Dr. Ahmed Haroon, please. Dr. Ahmed Haroon is an interventional radiologist at An-Noor Specialist Hospital. He's one of the seniors, and he does a lot of vascular and non-vascular work.
السلام عليكم. أولا كل عام وأنتم بخير ويا رب تكونوا جميعا بخير إن شاء الله. شكرا دكتور مأمون for this invitation, and now I will share my screen. This is a case presentation. As we see, complication during reconstruction of the central veins. So the procedure, first of all, was done by a vascular surgeon, and ethically I took his permission because I thought this is a very good teaching case. Number two, the weird thing about this case is that the complication happened not, the SVC was not the workplace. The complication happened in the SVC, while the intervention was in another place. So what is the case? She was 63-year-old female on hemodialysis, so left periculocephalic fistula, and she developed venous hypertension and high pressure during dialysis. So venogram was done, and the left periculocephalic vein was not opacified, and there was collaterals, as we see here in this image. You can see non-opacification of the periculocephalic vein. So venoplasty was decided for this patient. The venogram, non-opacification, and the venogram from the right side. This is what they have done, and we can see the right periculocephalic vein, SVC, and part here from the left periculocephalic vein. So this means that the SVC was normal in this patient. And as usually, they did progressive dilatation up to 10 millimeter by 40. This is the largest balloon they used. And the post-angioplasty, everything was looking fine. The procedure was uneventful. However, when the patient shifted to the ward, and let us say maybe 1 or 2 hours, she started to feel chest discomfort, dyspnea, lightheadedness, and this was progressive. So at this time, the vascular surgeon asked our opinion, and we asked to bring the patient again to angio suite, looking for any defect or rupture or leak from the site of intervention, which is left brachiocephalic vein. And we did venography. There was no extravasation. However, the patient was still in pain, and the blood pressure was falling. Also, she is on IV fluid. So what we'll do next? Definitely, there is some sort of bleeding happening in this patient, but it is not from the brachiocephalic vein. So to do is urgent ultrasound or CT scan, which is easily available at that time. So we brought the ultrasound in the angio suite, and we did ultrasound. We found hemopericardium, large hemopericardium, and so the cardiologist was requested, and he aspirated about 150 to about 150 ml blood, and then the patient intubated and shifted to ICU. 2 days later, the patient was not responding to treatment, and so they were seeking again for what is the cause of non-responsive treatment. As we see here in CT scan, there is endotracheal tube, thrombus left internal jugular vein, thrombus brachiocephalic vein. However, the brachiocephalic vein is patent, and there is no contrast extravasation here. And if we go to the superior vena cava, we can see here in this area abnormal contour in this area here. And here I thought from the start, I thought maybe a branch. However, it doesn't lead to a branch. And then the SCVC start to have its normal configuration. This is coronary formation. Again, the hemopericardium is still present. The second day, because the patient was not responding, they did surgery, and the surgeon didn't see any bleeding source, and so he did some repair, pericardial repair, and the patient then passed away maybe in the same night or second day. So what do you think in this patient? Number one, first of all, brachiocephalic vein perforation doesn't cause hemopericardium because they are not covered by the pericardium. So we have to look for another cause, and this was confirmed. This is one of my patient. This is one of my complications. There was rupture of the brachiocephalic vein, and it was covered by covered stent. And however, this is the appearance of perforation of the left brachiocephalic vein. There is a hematoma in the mediastinum, but not hemopericardium. And so I'm imagining that the wire manipulation is the cause of complication in this patient, because it may tear the SCVC or right atrium, or even if we have an anomalous cardiac veins that I was taught from the start, but it was not if there is a ring into the superior vena cava. Here I picked up 2 images, and it showed that the wire was not stable during the procedure. It was here, and then it was up, and in every series the wire was in a different location. This means that the wire was not stable during the procedure. And if I go back, provided that the surgical finding of no cause of bleeding, this could be a small pseudoaneurysm arising from the superior vena cava. So what we learned from this patient, how to avoid this horrific complication or this patient demise as we lost our patient. This patient, number one, by careful assessment before the procedure for the calculation profile and whatsoever as usual. And you should be prepared before the procedure your emergency kit. During the procedure, and this is one of the most important steps, is to place your wire in the IVC below the renal veins. I prefer also to be below the renal veins to avoid injury of the renal veins. So place your wire below the renal veins and use non-glide wire, and better to be stiff wire. And always keep an eye on the wire end. And I mean by that, the external wire end, the wire end, the end of the wire should be fixed during the exchange, and should monitor the patient clinically, if not under GA and visual signs. And also emergency should be available during the procedure. After procedure, you should be high suspicion. If any patient have dropping blood pressure, or this is a red flag, and you have to act immediately and take this seriously, and then consult your colleagues, and you may start with ultrasound, and you can do ultrasound yourself to save time, or CT angio immediately. And don't forget that complication may occur at a remote site from the site of intervention. Thank you.
Thank you, Dr. Ahmed Haroon.
Thank
That's
you.
a great lesson to learn. I'm not seeing, well, there is a question here says, drainage of pericardial effusion. Should we ask cardiologists to do it or just perform it in IR, by IR?
Okay, actually, after this case, I believe that we should have this skill. We can we can aspirate or can insert a drainage catheter into the pericardium. I believe that this is very important now to do it.
Another question it says that, are there any images showing the wire in the IVC? It might have pericardium.
No, the wire was in the right atrium or the SVC, never in the IVC. He didn't do like this. Yes.
Okay, excellent. Thank you so much.
Thank you.
There is one question for Dr. Ashur. It says that N95 for COVID patients, should they wear N95 for all COVID patients?
Of course, yes, because it is considered to be for healthcare workers, airborne, so N95 should be worn. Now, if, as I said, if there is if there's a problem with the fitting of the mask, failing the test, then they should use the PAPR, the powered air purifying respirator.
So that's usually N95 if there is going to be intubation or anything like that, right?
No, N95 for all patients, whether there is intubation or there is no intubation, for all suspected or positive COVID type patients.
Okay, thank you so much. Thank you so much, Dr. Haroon, for your excellent teaching points. So we'll move to Dr. Yusuf Zahrani, and he's going to give us a case, show us a case on uretero-arterial fistula, bleeding during a catheter exchange. So Dr. Yusuf Zahrani is an attending interventional radiologist at National Guard Hospital, Riyadh. Please go ahead.
Okay, بسم الله الرحمن الرحيم. كل عام وانتم بخير. قبل الله منا ومنكم صالح الأعمال. Thank you, Dr. Justiniya, Dr. Ashur, for organizing this webinar. So I'm presenting here a 66-year-old lady who has a history of metastatic rectosigmoid cancer diagnosed back in November 2014. She underwent neoadjuvant chemotherapy, radiotherapy, and surgical resection with transverse colostomy back in 2015, and she had positive margins. She had some progression of her disease, and about a year later, she underwent, actually she had some perforations around the local recurrence, so she underwent a major surgery with abdominal perineal resection, hysterectomy, total cystectomy, ureteric diversion, and creation of ileal conduit. And then she did well for 2 years, and then after 2 years, she presented with bilateral obstructive uropathy and hydronephrosis, most likely secondary to stricture at the area of the ureteric anastomosis at the ileal conduit. So she was referred to us to interventional radiology. We did a bilateral nephrostomy, and immediately in the same setting converted to bilateral retrograde ureteronephrostomies through her ileal conduit and through the stoma. Over the last 2 years, she did well, and she underwent just routine catheter exchange every 2 to 3 months. But about three months ago, she started to have some hematuria, bleeding through her stoma, sometimes requiring transfusions. She underwent CT scan twice in about 2 weeks interval, and her CTs were negative, so there was no areas of active extravasation or pseudoaneurysm or obvious fistulas formation at the area of the ureteric stent. So after 2 weeks of the last CT scan, again, she came with a new presentation. So she developed left deep vein thrombosis of the left lower extremity, and at the same time, she continued to have hematuria. Therefore, we placed an IVC filter for her. And again, the CT scan was repeated, and it was it was again negative CT scan, but this time there was significant compression by the right ureter extent. So if you look at this axial CT scan, the right common iliac artery is almost not visualized, where at the area of the crossing by the right ureteric extent of the right ureter nephrostomy. So we suspected that this is the source of her problem, and this is the source of her hematuria. So we brought her to NGU, and it was actually done by one of my colleagues. We did pelvic angiogram, and it showed again the area of severe focal stenosis where the right ureteric stent crossed the common iliac artery. Although she was not having any symptoms in her regarding to the to the arterial stenosis, so we thought this is the source of her bleeding. So we proceeded with the stent. We placed a covered stent, VPX stent from Gore, 8 mm stent was placed, and it was the area was treated. So again, she continued to have bleeding, and then after a week later from the iliac artery stenting, they repeated the CT scan, and the CT scan was again negative, but she continued to have intermittent hematuриas with low hemoglobins. So they repeated the CT scan. The CT scan was negative, but the CT scan is showing her bilateral ureteronephrostomy is migrated, especially the right side is significantly migrated with the tip almost in the distal ureter. So this time, despite the hematuria, she was just referred to us for routine exchange. So the patient was admitted through a short stay. So the procedure was actually booked on Thursday, and it was the last case of the day, which is classic with these cases. So I thought it's just 5 minutes, do it, and then head home. So she was on our table. So I did the exchange of the right side over a wire, and it was actually dripping clear urine on the right side. So I changed it. I positioned the catheter, confirmed the position. So I pushed the wire through the right ureteronephrostomy catheter, and it was black blood. Then I just removed the catheter over a wire, and the minute I took the catheter out, there was a gush of fresh blood, like a fontaine through her ileostomy. So what I did, which actually I think it was a good step to save this patient, I just pushed the catheter back, her nephrostomy UNS catheter back over the wire for tamponade, and then I just pressed on her abdomen. So I did pressure on her abdomen just like blindly. I didn't know what was the source at that time. And the patient, she continued bleeding, and I was sucked in blood. So she became tachycardic. So we'll give her IV fluids. We immediately activated CCRT team, and we start. So I had my nurses and technologists around. So we start immediately prepping her left groin, and we did puncture, and then I placed the sheath, and I asked the nurse to continue pressure on her abdomen and stoma area, and we proceeded with angiogram. And then the angiogram through the left side. At this moment, actually, my colleague Dr. Bashir joined me, and he continued pressure. So I just did angiogram. There was significant plush, and this is the source of her fistula from the distal left common iliac artery. So immediately we proceeded with a stent. So I placed another VPX balloon-mounted covered stent from Gore, 9 mm by 59 mm stent, and it was completely excluded the fistula at this point. So the patient was under the care of the CCRT team and was referred to ICU, and the next day was discharged from ICU. Actually, this patient is a complex story. She has local progression of her disease with invasion of the ureter. So she continued to have the bleeding, and we continue trying to save her and battle against her hematuria despite the pandemic. So 3 days ago, she came back again with bleeding. One of my colleagues did angiogram. I didn't bring the images. There was no fistula from both sides. And So he did angiogram of the kidney. There was no clear extravasation or fistula, but this is the long ureteric artery, which could be the source of her bleeding this time, which was very difficult to cannulate. So as of today, actually, the patient continued to have bleeding, and we decided just to place a balloon for tympanad and convert it to a regular nephrostomy. So it's actually it's a tough situation to treat her hematuria, but still she's having hematuria. So we end up just placing a balloon in the ureter for tympanad this time. So the ureteroarterial fistula is a rare condition. It's a fistulous communication between the ureter and the aorta. It could be either, or the internal, or the common iliac arteries. It could be either native ureters or ureteric diversion, like our case. It's more common in females, and the mortality is high, reaching up to 23%. These conditions are statistically more common on the right side. There are two types. There are either primary, which is very rare. It could be secondary to vascular pathology like large aortic aneurysm or vascular malformations, or secondary, which is the commonest type due to either previous pelvic surgery or radiation or ureteric stent, or a combination of all the three factors, like in our case. So this is what this scenario. So usually there are the stents or the catheters in the ureter with the chronic movement and erosions of the area. It results in the fistula. Sometimes there's a small aneurysm communicating with the, or direct communication with the ureter in this area. So the treatment options used to be a surgical, but nowadays the endovascular is replacing the surgical options, which is mainly covered stent, like in our case, to exclude the fistulous communication. There are so many publications in the literature. It's actually rare in the the number of cases around 150 in the literature. And the endovascular treatment with the stent grafts is a safe technique, but always there is a chance of recurrence of hematuria, like in our case. So the lessons here, always keep this diagnosed in your mind when you do these cases in a patient with ureteric stents or catheters, and be ready for dramatic bleeding. Even in these cases, you should be ready with to have like a backup, or sometimes you can just do it under general anesthesia just in case of bleeding or rupture, and always be ready for stenting or coiling if it's like small branch or pseudoaneurysm. Thank you very much.
Thank you so much, Dr. Yusuf Al-Zahrani. Excellent case, and we really appreciate it. And the way you managed it was great. We have a question here. Says, how about embolizing the ureter itself?
In our case, it was clear, obvious fistula. We thought this is the final, it will be like the final solution in her situation. But with her deterioration, until today, she's still having hematuria, which is about 2 months, around 2 months from the stenting. We are thinking of this as a last option, just to, so we placed the balloon, as you can see in my slides, which was placed today by my colleague, Dr. Arabi. And his plan is probably we can think about just embolizing the whole ureter with like glue, or place even a covered stent in the ureter. I don't know what's the like final solution in our case.
Thank you so much. We appreciate it. So we'll move to the next case, and with Dr. Nasser Al-Gharim, and he's going to talk to us about management of type 1 endoleak complication. Please proceed, Dr. Nasser Al-Gharim. He is actually a solo interventional radiologist at the southern borders in Najran, and we appreciate all your hard work, Dr. Nasser. Please proceed.
Thanks, Dr. Mamoun. Good evening, everybody. Assalamu alaikum wa rahmatullah wa shahr mubarak. I will share my screen now. I think this is my screen. Share. Yeah, F5. Sorry. It's not working. Oh, okay. My case is about endoleak type A management, which is complicated by multiple complication, which you will see it soon. This is a 60 years old lady, post RTA, TVAR type 2, grade 2, presented 3 months after the procedure. She was presented a few times to the ER complaining of cough and shortness of breath. Last time she was collapsed in the ER, and we will go for that. This is the picture of the first trauma RTA, which presents with grade 2. It's about 15 millimeter distance. It's grade 1 or 2. Traumatic aortic injury, which was stented successfully, and there's no beaking here and here to suggest we have a leak in the future. That happened. Discharge chest X-ray was okay. She has also humeral fracture. 2 months later, she presented to ER. Few visits to ER complaining of cough and shortness of breath. Chest X-ray was done, and they think she was asthmatic. The patient was also asthmatic, and they treated for asthma and discharged. We have noticed here, there is a soft one retrospective. We have soft tissue thickening from the stent margin, which means there's some expansion. Same again, if you look in the X-ray, we have this thickening. Again, on January 13, that day of admission, she was in ER with more thickening, and she was about to be discharged because cough, shortness of breath. Suddenly, she collapsed and get desaturating. Intubation was done in ER, and this is the post-intubation chest X-ray. We have complete opacification of the left hemothorax with shifting of the medial. If we go back, we have here shifting of the trachea to the right, but now it's central because we have a collapse. Afterward, they shifted, after intubation and resuscitation, she was shifted to CT scan. CT showed large pseudoaneurysm and expansion of this pseudoaneurysm. This is the stent, and this is the pseudoaneurysm compressing the left main bronchus. If you see here, left main bronchus is occluded, and large pseudoaneurysm, large hematoma with mediastinal shift. We proceed to angio suite. This is the reformat. We have tortuous anatomy of the neck vessel. If we see here, this is the right brachiocephalic artery, left common carotid artery, and this is the pseudoaneurysm here. We have a complicated anatomy here, the same. I take her to angio suite, percutaneous approach, bifemoral angio was done. This is the angio. We have the brachiocephalic right, left common carotid, and subclavian. We have the pseudoaneurysm going down up to here, here it is here, but faintly, up to here. So I decided to overstent, put a stent in stent for treatment of the, the stent was placed inside, pulled back a little. We have this around, and if you notice, we have here a small linear hypodensity, which basically just unfolding of the left subclavian, which we saw it in CT. It was unnoticed for me, actually. I deployed the stent, and this is the picture. I lost the blood in the right brachiocephalic and right carotid artery. I have faint blood going to the left common carotid. That time, what to do? The surgeon beside me, I asked him, this is the picture before, this is the picture after. I check pulses in the neck. I check ultrasound by the carotid artery. There was no flow. Surgeon said, we can't do any option. What I did that time, I don't have option. I go directly just to puncture under ultrasound guides the left brachial artery, which was collapsed, macropuncture. I passed my combi catheter, and I inject contrast, and I have this appearance. It's communicating. When I inject contrast, it's go in the right subclavian and in the left common carotid. So means there is a flap or unfolding, and the stent is here. This is the end here, and uncovered portion, 4 millimeter uncovered. I immediately passed a live stent, deploy it. That's my only option I do. That was 8 minutes. Calculate from the deployment of the aortic stent, and this time it was 8 minutes. I am afraid of to have brain ischemia. This is the picture after. I got happy, I got relaxed at the time when I saw right subclavian artery filling and all the neck vessel. I check again blood pressure, come back, but it's still low in the right arm. Got a little bit comfortable. The patient, I finished with the closure device. The patient stayed in the hospital 12 days. CT scan was done. Second, she was intubated at that time and sedated. We don't know the mental status. She have infarction. CT was done for the pain. It was normal in the second day. 1 month later, the patient presented with anemia, melena. She has a chronic melena. And at the GI OBD, she was having blood hemoglobin dropping from 10 to 9, then to 7.4 in 1 week. Endoscopy was done and shows no obvious active upper GI bleeding. Few days later, she was admitted for anemia investigation, and more they think, we have another endoleak. The cardiac surgeon was insisted maybe we have another endoleak. So CT was done, the neck is okay here, good. We have good flow in the neck vessels. If we go back, the stent is still there, the aortic stent. We have air locules around the stent. The hematoma is gone, but no active bleeder. We have air locule. This may be due to infection, maybe fistula, I don't know. Actually, I revised the image. I was that time not in Iran at this CT scan. So we find, when you see here, we have a communication with air. This is the esophagus, maybe, we don't know. Is it esophagus perforation or aortoesophageal fistula communicating and non-communicating? But there was no hemoptysis.
2 minutes.
Yeah, okay. Then I will pass fast now. This is the CT. Endoscopy was done, and the patient and the endoscopist said that he has a severe gush of blood, and the patient collapsed and died on the table. What happened? Was it a ruptured aortoesophageal fistula? Was it iatrogenic perforation of the stent? And I read literature, we have aortoesophageal fistula after thoracic aortic stent. It is a rare but a catastrophic complication, and it presents by hemoptysis and sudden bleeding, or usually we have intermittent. Diagnosis is difficult for it. This is the literature. So what lesson we will, I think we have to learn from this case? Do we need to stent type 1 and type 2 traumatic aortic injury or no? This discussion has a lot of debate. From my opinion, and I ask many experts, they said treat any traumatic aortic injury. We have 2 cases passed away because we don't treat them. This is type 2, the same case, our case, we discuss it. What other possible solution to treat the situation and the post-stent complication? This is maybe reconstructive surgery, which we don't have it, or it was acute, you can't do it, and would have a higher risk. How definitely to avoid this scenario? We have here the trachea is compressed, maybe the esophagus is compressed, and maybe we can get esophageal ischemia. Was it worth to be more cautious doing endoscopy with the CT signs, which we saw it? What was the best management option for melena? This is, I think, did the endoscope bust to the stent, or the stent was rupturing? I don't know. Thank you.
Thank you so much.
Yeah, welcome.
This is an amazing case. It's actually nerve-wracking, and I mean, the time you took, honestly, to really just get the brachial access and get your stent was really quick, and you did you know, what you have to do, and then you have from, it's like one complication after the other. So
Yeah,
but
I
we
think
really appreciate your sincerity and sharing your case with us. Go ahead, please. What do you want to say?
I think at that time, uh, I hope I never go to medicine at that time, because first you feel you kill one person. You have a person who was dying in front of you. Yeah, it was a very hard actually. And I asked my friend the surgeon, can we do bypass and transposition? But the patient under anesthesia, he said, no, I don't have experience. Yeah, this is the situation here. Thank you.
Allah يعطيك
Allah.
Jazakallah khair. All right. Just to kind of, for the sake of time, we'll move on to the next case. I appreciate it, Dr. Nasser Al-Gharim. Really thank you for sharing this tough case. So the next one is going to be Dr. Bandar Al-Dhafiri. He is an attending interventional radiologist in the Eastern Province, King Fahad, I think, right? The Bandar?
Yes, yes.
Hospital. And he is going to show us a case about SFA occlusion, failed re-entry after a subintimal passage. Please proceed, Dr. Bandar. Thank you so much for doing this. Let me just stop my sharing. You can share your screen.
Okay. السلام عليكم ورحمة الله وكل عام وانتم بخير. Thank you very much for inviting me and Ramadan Kareem for everybody. This is just an example of how a straightforward, relatively simple case can go in very complicated situation. Many lessons we can learn from this case. Our patient is 62 years old gentleman. He's diabetic, hypertensive, presented with left leg intermittent claudication. The walking distance was almost less than 100 meters. He's a physically active person. He's working as a school guard, so he's moving. His physical activity actually is good. By classification, he's Rutherford class 3 with no tissue loss, or Fontaine class 2B. So after physical examination, evaluation, CT scan was done, and it showed total occlusion of the left superficial femoral artery. So as we do usually with those class of patient, we put him on conservative treatment. Which usually the lifestyle modification plus some medication, statin, antiplatelets, plus diabetes and hypertension control. So after 4 months, he came back to the clinic, and he didn't really show any significant symptom of improvements. And so we decided to do intervention for this patient. The patient was taken into, of course, after we admit him through 1 day admission unit through the right groin, peripheral angiography. As you can see, there is total occlusion of the left SFA, only proximal segment which is diseased, narrowed. We can see it here. At the thigh, there is nothing at all, with reconstitution almost at the after adductor canal at P1 segment of the popliteal artery. So as usual, this is the runoff of this patient. Mainly the runoff is single posterior tibial artery. So we try to revascularize. We try to go first intraluminally. As you can see the wire here, it's going into the lumen. Then after facing relatively heavily calcified plaques, the wire went subintimally, and then we will continue with the catheter till we reach to the open segment of the popliteal artery. We inject contrast to make sure that we are in the lumen. Then we proceed with the balloon angioplasty and stenting. As this patient we passed subintimally, so we didn't prefer to use any atherectomy device. We went directly with balloon angioplasty and stenting. Then follow-up angiogram showed no flow to the stent totally. There is nothing flowing to the stent at all, which is a bit strange for this case. So we try to investigate what's going on. in this patient. We just review some images during the procedure, which was taken at the before intervention. And if you can look carefully here to this image, you can see the wire passing almost beside the artery, and there is almost a lucency between the lumen of the popliteal artery and the wire. So that's mean that the wire is not going back to the lumen. It's still subintimal. That's why there is no flow in the stent. There is no outflow to this stent. So we try to go intraluminally. We know that the open segment or the re-entry point should be somewhere here on this segment of the popliteal artery. So we did some manipulation with the different guide wires, catheters, some balloons, but we failed to go back to the lumen. And there is other option. Sometimes we might do for in retrograde revascularization. We puncture the tibial vessels, then try to snare the wire, flossing techniques or safari. But for this patient, we didn't prefer to use this technique because he's a claudicant, not CLI patient, and he has only single run of vessels. So what to do now? Patient is a claudicant, still he has no critical limb ischemia, and we thought the best thing to do in this patient to use Outback re-entry device, which was not available at our angio suite during this procedure. So we discharged patient on anticoagulation, kept him on other medical treatments, and we called him, we gave him appointment after 2 weeks vascularization. So after a few days, patient has almost wrist pain. Before the intervention, he was at least walking less than 100 meters. Now he has wrist pain. He starts to have cyanosis of his left big toe. So he's now functionally moved from Rutherford class 3 to Rutherford class 4. So we call him and we brought him back almost after 10 days from the procedure. We used the Outback. This is the picture of the Outback. This is the point of re-entry or supposed re-entry. So with some manipulation, we pass the wire. Outback is a great device in those situations. So we pass the guide wire and we inject contrast to make sure that we are in the lumen. We were in the lumen. Then we start to dilate with balloon those occluded stents to break the channel between subintimal space and the lumen with some balloons. So after we did this, still there is no flow in the stent, and moreover, there is almost distal showering of the posterior tibial artery. There is total occlusion of the posterior tibial artery, anterior tibial, and there was nothing flowing to the foot. So what to do again? We decided to put him over night thrombolysis. We used TBA for this patient. Then after 24 hours, brought him back to the angio suite. And this is the run-off angiogram, follow-up angiogram. You can see the flow through the superficial femoral artery into the thigh to the popliteal artery, and there is good revascularization of the tibial vessels with good run-off vessels. So now he goes back even better than pre-intervention stage, but patient was discharged home on anticoagulation. Always in those cases, we put them on anticoagulation for 2 weeks. Symptom improved. Now he's walking almost about 500 meters. The discoloration reversed totally. So there are a few lessons from this case. First, we should think twice before treating patient with claudication. Really, we have to exhaust our non-invasive options, medical treatment, exercise, lifestyle modification, smoking cessation. Those have very good result on some patients. Because any complication happen, it might convert this patient from claudicant to critical limb ischemia. Always keep re-entry device on shelf. Always. Don't do those procedures without re-entry device. Whatever device you prefer to use, but at least going to those patients, most of their vascularization will be subintimal, and you may face those complications. Always take time in each steps. Sometimes because those procedures almost routine, So sometimes we skip some important details that might get you in a trouble. So always pay attention and give time for each stage of the procedure. And finally, have a good connection and relation with your colleagues, vascular surgeon, ICU, other doctors, because if something happen, at least you can ask for help. Thank you very much.
Thank you so much, Dr. Bandadafiri. This is a great case, and I really appreciate it from you and all the speakers, Dr. Nasser and everyone else, to share such a complication, such a complex case and a difficult case, like in public. And the whole thing and the whole idea behind that is to show that we're here to kind of teach each other. It's not like, and when something goes wrong with you, you don't want the same thing to happen with us. Just for the sake of time, we'll take one question. It says, did you consider bypass since he is relatively healthy claudicant? And
bypass will be a good option also for this patient, but this patient prefer to go for endovascular treatment.
All right, thank you so
much.
much.
It is a good option, yes.
We appreciate it. Okay, thanks a lot. So now we'll move to the next speaker, who's Dr. Saad Al-Gahtani. He's an attending interventional radiologist in the military hospital in the South. And he's gonna talk to us about recanalization of SFA, intrastent occlusion, an unusual scenario. Welcome, Dr. Saad.
Assalamu alaikum wa rahmatullah. So it's a pleasure to be among this webinar tonight, and I wish Ramadan Kareem to everyone. My case actually about recanalization of intrastent occlusion of SFA, which is an unusual scenario. I'll start by the case scenario. It's about 65 years old male, diabetic hypertensive, cardiomyopathic with poor renal function actually. He has right lower limb, wrist pain, and worsening claudication with past history of recanalization and stenting of total occlusion of right SFA 15 months back. The CT angio done at the time showed right SFA complete occlusion of intrastent as well as the upper third of SFA proximal to the previous stent. And this is the CT angio with curved reconstruction showed the, as you may see here, the intrastent occlusion of the upper half of the stent extending into the upper third of the SFA. The patient was taken for the angio suite for the recanalization of the occlusion and the reopening of the whole artery. As you see, the angio showing the total occlusion of the SFA upper third with the stent itself and with the reconstitution of the flow at the distal, at the distal part of the stent with the popliteal, which was normal. We did crossover and recanalization using the Teromo guide wire supported by 4 French vertebral catheter, and it was in usual fashion. It was a little bit difficult during recanalization, but the guide wire passed through the whole occlusion, including the stent. The initial angiogram after the dilatation of the whole occlusion using a balloon of 5 millimeter diameter was okay. There was nothing special except for the, if you can appreciate, the thumbprint at the upper half of the stent, which was worrisome. Why is that? We thought it's at the beginning like thrombus or remnant of the atheroplate. However, we repeated the dilatation another time with a longer time, and the angio showed a good flow, but this thumbprint stay in the place. For which that time we assumed assumption, I wouldn't say now, but I'll show it to you on the next image. So we did like a lateral view, and as you see, the guide wire actually recanalized or we recanalize into the intimal space, then it repass inside the through struts into the stent. And with the repeated dilatation, the subintimal space was okay and the flow was okay. However, it wasn't optimal. We did an angio in this position. And as you may see in the angio on the left or the right side of the screen, it was passing. However, during the repetitive angioplasty, the intrastent material was very solid that it didn't or couldn't be squeezed. So at this point, we decided to continue the angioplasty because we cannot insert any stent, since we may not pass through struts with the stent. If we can pass, it might not be open totally, and if it opened, we might not be able to pass a balloon inside the stent to reopen. So we decided just to keep doing angioplasty with long inflation, and we increased the diameter of the balloon. This is the angiography after the long dilatation using 6 millimeter diameter balloon, and the flow wasn't compromised, was okay. And at this point, we decided that the procedure is successful and no need for any further step. This is the flow without any, it wasn't compromised. Few words about the in-stent restenosis. It is, we have to know the pathophysiology of the recent lesion, that it's complex and differs significantly from the de novo atherosclerotic lesion. Actually, it's consists of heterogeneous and of collagen network mixed with smooth muscle cells with a high water content, and that will make it very solid, and sometimes it's much difficult to recanalize it as compared to the usual atherosclerosis of native arteries. The calcium is rarely present in in-stent stenotic lesions. As well, the incidence of femoral-popliteal artery in stent stenosis or occlusion ranges from 15 to 32% of cases, and it occurs normally between 15 months after angioplasty or stenting. If the occlusion occurs after 2 years of the procedure, it's not due to the new intimal hyperplasia with collagen as supposed to be, but is rather due to new intimal, is due to a pheromatous disease, more likely. The management of interstent occlusions has a big variety of options, starting from simple balloon angioplasty using the regular balloons or drug-eluting balloons. However, drug-eluting balloons is not recommended without debulking, because the paclitaxel will not go to the intended layer of intima, the original intima, because there's a new formation of fibers and new small muscles. The other option is using the stenting after the dilatation, using bare stents or covered stents or drug-eluting stents. As well, debulking using the catheter atherectomy plus minus balloon angioplasty or drug-eluting balloon. And the best two or the two way of management that are superior to the others is to use the drug-eluting stents, which showed good or long patency as compared to the angioplasty alone, as well the atherectomy in the new trials with drug-eluting balance, so show superiority to the other options of treatment. It needs a long time to elaborate on the different types of the management.
1 minute.
So, yeah, my message here is to know that the endovascular treatment of interstent stenosis or occlusion has advanced technically, and we have to be very flexible to change our strategy during the endovascular therapy. And we have to explore all the points once we have any doubt or any unusual image to exhaust ourselves and exhaust the angio machine to see what's going on exactly. We have to be familiar with all of the techniques which have been developed up to date. Thank you so much.
Thank you so much, Dr. Saad Al-Qahtani. An excellent case too. I mean, we can't select the best case here. Like all cases are great. And I think, as you mentioned, this shows the importance of like angulations, making sure that you are inside the stent and before ballooning. And that goes on all stents everywhere. I think venous, arterial, biliary, wherever you go. So we have a question here about like, what about puncturing the stent initially, like before you do the recanalization from there? Would you consider that option, or like use a J wire to recanalize at the beginning? So like the two parts of the question. One is the intrastent puncture and the other one is J wire.
Okay, J wire, it might not be helpful because you need like straight tip or angle tip to be able to go through small channels into the occlusion. The other option, for example, in our case, when we discovered that we passed in the subintimal and go back into the struts, we tried to recanalize again from above, but we couldn't because the subintimal place is already dilated and the guide wire was going each time directly to the subintimal. Somebody may ask why not to go from retrograde way. The patient is claudicant and with a single runoff, and we didn't like to compromise the flow going down. As well, we considered the flow was excellent and rapid without any compromise. So we thought the angioplasty is going to be enough in spite of the going into subintimal, then back into the struts and then the stent with a plan in case if the patient come again with occlusion, we will do antegrade and retrograde, probably recanalization. However, the good news, the procedure was done in July 2019, and up to date, the patient has no complaint. Totally, he's okay, no more claudication or wrist pain, up to date.
Excellent, appreciate it. I mean, for the interest of time, we'll move to the next one, but just a quick point is about bypass again. So this is like you want to go endovascular before you go bypass if you can achieve that, right?
Exactly, I prefer to.
Okay, all right, thank you so much. So we'll move to, thank you so much, Dr. Saad Al-Qahtani. We'll move to the next speaker, Dr. Muhammad Arabi. Everyone knows him. He is an attending interventional radiologist at the National Guard Hospital in Riyadh. And he's the editor-in-chief of the Arab Journal of Interventional Radiology, which all are encouraged to submit papers to. And he's going to talk to us about endovascular Warren shunt for variceal bleeding control. Please go ahead.
Assalamu alaikum.
Assalamu alaikum.
Share screen.
All
right. Okay. Do you see the presentation now?
See the presentation, but we don't see you.
Oh, okay. Do you need to see me?
Hopefully.
Probably not. Assalamu alaikum. حياكم الله جميعا. كل عام وانتم بخير. إن شاء الله next Ramadan we'll see you all live, not online. So this case just happened to be over the past few days during the COVID time, and it's interesting in a way that probably you have to think outside of the box and think of other surgical techniques for the control of variceal bleeding. So I have no disclosure. So this is a 40-year-old male who's known to have alcohol-related liver cirrhosis. He's a heavy smoker, history of treated brucellosis. He had a focal lesion, which is suspected to be Leyrat's 4. And he's also known to have severe portal hypertension. He had the previous episode of esophageal varices ligation. He presented on March 21st, which is exactly 1 month ago, with hemorrhagic shock, active bleeding from the rectum. He was intubated on mechanical ventilation on 2 inotropes. His blood pressure was on the low side all the time. Hemoglobin was 39, kept transfusing him several times. Nearly over the early days, he was transfused like nearly 50 packs of blood, fresh fluorescent plasma, and platelets. He had the 2 gastroscopies. Both of these gastroscopies showed no active bleeding from the upper GI. Yet they did the banding of the esophageal, one of the esophageal varices. The endoscopy showed the healing antral ulcer with no bleeding, no fundal varix, and he was labeled as lower GI bleeding, probably due to the portal hypertension. So suspected to have hemorrhoidal bleeding, but neither GI or the GS were able to do anything for him because he was massively bleeding despite all the transfusions. So when we got called about this patient, his MELD score was 17, although his MELD score before the presentation was better than 17. His total bilirubin increased over the early days of the admission because of the hemorrhagic shock, and his hemoglobin again is 39, platelet count was 98, and his INR was 1.4, ammonia was 98. As you can see, the vitals all are on the low side. So just running through the CT, which was done just in order to see whether he has any active arterial bleeding or any to identify any source of bleeding, you can clearly see that the patient has extensive gastroesophageal varices, gastrorenal shunts, and also you can see here, let me just run through it. You see very prominent mesocolic shunts here. You see a very prominent mesorenal shunt, which ultimately drains into the left renal vein. So we accepted the case to do a TIPS for him, and it was a kind of straightforward TIPS. And we punctured into the portal system, and the minute we entered the portal system, you can see the flow is completely reversed, and everything is draining through the collaterals into the gastroesophageal varices, into the mesorenal shunt. It's not that, it's not typical of splenorenal shunt. It's actually IMV ultimately draining into paravertebral veins, then ultimately draining into the left renal vein. The portal systemic gradient after the TIPS dropped to 12, which is not the ideal for someone who's bleeding. You would rather always to have it between 5 to 10, but in this case, because he was massively bleeding, we decided, okay, let's give him a chance. Maybe the TIPS will improve him a little bit. Now the question is whether to embolize these varices or not embolize them. As I said earlier, we were 100% sure that he's not bleeding from the upper GI, so it was not gastroesophageal bleeding because he was scoped twice, nothing in the upper GI tract. So basically he was bleeding somewhere beyond the ligament of Treitz. So it's either small bowel varices or it's like colonic or hemorrhoidal bleeding. When I did the direct injection in this vein, let me show you here. This is it here. You can see that the flow is it's from the IMV into these collaterals, but there's no filling of any hemorrhoidal veins. So it's not hemorrhoidal bleeding. And on the CT, there was no filled, there's no filling of the hemorrhoidal veins. So now the question is what to do in the next if it keeps bleeding. This patient actually kept bleeding despite the TIPS. He slightly improved in terms of hemodynamics. He did have persistent bouts of lower GI bleeding requiring repeated transfusion, and he started going into the IC. So as you can see from the labs that he's trending down, up and down. His lactate was trending down, then went up again because of the recurrent bleeding. Total bilirubin started going up because of the shocked liver. So we brought him back the second day, and the portal systemic gradient at the beginning was 18, was increased again. If you do main portal vein injection, the TIPS is not fitting directly, although it was, if you inject in the TIPS itself, the flow is quite brisk, antegrade, but if you inject somewhere here at this exact point, flow is completely reversed. And this is the injection here. You see the flow is completely reversed. So we did a stent extension. It did not really help in improving the TIPS parameters. So we decided to go ahead and start embolizing some of these varices, embolized a bunch of gastric, esophageal varices in order to try to eliminate any of these possibly bleeding varices, which were not exactly which one is bleeding. And as you can see here, everything is connected to each other. This is connected to the mesocolic varix. So if you embolize this one here, it might open up in different channels. So we were not 100% sure where to go, but we did some embolization in order to start eliminating some of the these collaterals and varices. At the end of this session, we completed multiple embolization. I will just go through some of them. We did again another injection in the mesorenal shunt, and there was no filling of any hemorrhoidal branches that you can identify in order to embolize or can cannulate and in order to embolize. So at the end of this session, we just, as you can see, we did extensive coiling, extensive gel foam here, and multiple coils everywhere. And the portal systemic gradient at the end of the session was 10, which is kind of okay, probably. But as you can see, again, any injection in the main portal vein will still fill this big, very big collateral. And now the question is what to do next, because patient kept bleeding and dropping hemoglobin despite the transfusions. And you can see his hemoglobin was approaching in like 50s, 40s. Platelet count is going down because of the DIC. Lactate is going up again. So now the question is whether to keep embolizing these endless varices, which we don't know which one is the bleeding. Whether BRTO is possible. This is technically not BRTO, is because even if embolizing this big shunt, the mesorenal shunt, will probably increase the portal hypertension, and it might risk him to worsening symptoms because we don't know which one is bleeding. And whether to consider any sort of arterial embolization or maybe parallel tips or additional tips in order to further decompress the portal system.
1 minute.
So, yes. So what we decided to go is do arterial angiogram just to exclude any arterial source. And this is the IMA. You see a very prominent filling of what looks like hemorrhoids. But the filling is antegrade, it's not retrograde, so it's not of a concern, but still we embolized the superior hemorrhoidal arteries. We did the prophylactic GDA embolization. We did, you see the splenic vein fitting retrogradely into the mesorenal shunt. So at this point, we decided in order to split the, to minimize the portal hypertension is to split the system. And this is alternative, surgical alternative to decrease the portal pressure is to do what's called wire and shunt by diverting the splenic flow into the left renal vein. But the patient already has a shunt, so we decided to do a splenic vein embolization in order to force the flow from the splenic vein into the left renal vein. Before this, we did the esophageal variceal embolization in order to eliminate any risk of recurrent esophageal bleeding. And we completed this with this Embolizing plug, which is 18 millimeter, 16 millimeter length. And immediately the pressure in the portal system dropped from 36 to 26. And the gradient went down from, it was 10 before, and it went down to 6. And after this session, the patient completely recovered from bleeding, despite but because of the prolonged hypotension, he had watershed infarcts. Some of them converted to hemorrhagic transformation, but ultimately the patient stabilized, extubated a few days later, and the GCS was 15 at over 15 at discharge, no hepatic encephalopathy symptoms, and he was discharged actually 2 days earlier. So the point here is you have to consider all these, this long list of portal systemic collaterals when treating these patients. And you have to know the flow dynamics and classification of all these collaterals before treating these patients in order to make sure that you are not worsening the symptoms in these patients. And the wire and shunt is a surgical alternative to TIPS, actually. It's a very old surgical alternative. They just cut the splenic vein and connect it to the left renal vein in order to decompress the portal system. There are several variations to it. You can connect the splenic vein directly. You can do end to side to side. But this kind of procedure is obsolete because of the TIPS. But sometimes if you have a natural TIPS, natural shunt like this one, may be better to consider this and keep it in your mind. So this is a kind of a quick review on this subject. It's well-known in the surgical literature. Probably it's obsolete now, but maybe you should consider it sometimes and think outside of the box. So what I need to share with you is these patients can be quite complex, and you have to think of personalized approach to these patients. You have to understand the pathophysiology and the portosystemic collateral pathways, and always think outside the box. It's not one size fits all patients. You have to think of other alternative approaches other than TIPS and BRTO and other embolization techniques. Thank you so much.
Wow, what a case, Dr. Arabi. Thank you so much for sharing it. And it's fresh and you put it all together very quickly. So we really appreciate it. For the interest of time, we'll move to the last case with Dr. Salim Bayounis, who's an attending non-vascular interventional radiologist at King Fahd Medical City in Riyadh. And he's going to speak to us about percutaneous treatment of a large aneurysmal bone cyst. Please go ahead.
السلام عليكم ورحمة الله وبركاته. أولا كل عام وأنتم بخير ورمضان مبارك على الجميع. I'm really happy to be a part of this webinar. Thank you for the Saudi IR Society for this invitation. I'm happy to share with you our case, which is the first cryoablation case in the region, which is the percutaneous treatment of large pelvic aneurysmal bone cyst. So first of all, I have nothing to disclose. Starting with the clinical presentation of the case, she is a 16-year-old girl who has a long-standing, around 2 years, left hip mechanical pain with a score of 6 out of 10, and a constant burning sensation and dysesthesia over the inner aspect of the thigh, which was on and off, and then became a constant, and on and off muscle cramps with a left hip limited range of motion. What we can see here that there is almost absent pubic bones except of the ischium, and also that the lesion, there is a huge expansile bony or osteolytic lesion involving the pubic bone, and extending to the acetabulum, and mainly the medial aspect of, or the medial wall of the acetabulum of the left hip. This is her MRI that shows a large cystic or multicystic with thick internal septations involving the pubic bones, with perilesional adjacent soft tissue edema. And what we can see here on this axial view, that the obturator nerve is almost strangulated in the obturator canal due to the mass effect of this huge mass, which is deviating also the pelvic and the pelvic viscera toward the right side. On the CT scan, it was mainly to see if there is any ossification, or and also to see the relationship with the acetabulum and the left hip joint. What we can see here, there is very thin bony wall of the medial acetabulum, and we can see that the supracetabulum is almost unremarkable. This was 3 months before the procedure. So then the diagnosis was established radiologically and pathologically by taking a biopsy from this lesion, which turned out to be no malignant cells, and the radiological appearance was in favor of aneurysmal bone cyst. So in the multidisciplinary team meeting, we met and put all the possible or the possibility to treat this patient from the medical, surgical, oncological, and interventional radiology teams, and we turned out to we debate a lot: is it a surgical treatment or an IR treatment? A surgical treatment for such lesion, which is an aggressive, with no any cortical bone remnant, and in this case. So and also the involvement of the left hip joint, it poses a lot of or a huge or morbidity for this patient to go for surgical procedure with the possibility of left hip, total hip arthroplasty. So from our side, we decided to go to treat this patient percutaneously. And what was the decision was the cryoablation. Why? We know that the sclerotherapy, there are multiple and variety of options to treat such cases or such tumor or bone lesion percutaneously with the sclerotherapy. There are a lot of sclerosing agents, fibrosing agents, but in such case, because of the it is very large lesion, a huge lesion with the compressive with the compression on the obturator nerve, so we are seeking for a faster decompression, mainly of the medial component of the lesion. For the cryoablation, we know it was earlier involved in the treatment of bone cyst as an adjuvant therapy to the surgery, where it entails a pour of liquid nitrogen through stainless steel funnel into the tumor. They call it cryosurgery. So for the technique, first of all, we have to plan the positioning of the cryoprobes, how many cryoprobes, what are the noble structure that we have to take care of. We have to avoid collateral damage. So we have the obturator nerve, we have the vagina, we have the anal, we have the anus, we have the urinary bladder on the medial aspect, and we have the left hip joint on the lateral aspect of the lesion. So if we go back into to the MRI, we can see that the acetab, the supracetabulum was almost unremarkable. So we were concentrating on this component to achieve as much as decompressive effect using the cryoablation. But unfortunately, during the CT after the general anesthesia and doing the pre-op CT scan or CT planning, we saw that, or we discovered that the lesion, it is aggressively and it is still active, which is extending into the supracetabulum, that may weaken the part which is the most important part of the hip joint, which is the weight bearing component, which is also vulnerable for or to compressive fracture.
2 minutes.
So we treated we went and treated the soft tissue component and with a modified modified freezing thawing protocol, 3-5-5-3 minutes, because of to avoid the damage of the obturator nerve, and we also succeeded to achieve a hydrodissection of the vagina and the urinary bladder. The 1 month follow-up clinically was that the patient got mild improvement on the of the obturator nerve compression, but still she had mechanical pain of the left hip joint, and that was expected because we didn't touch the supraacetabular component. So this was the 1 month follow-up of the CT scan. What we can see before and after, there's almost a significant 50% of decrease in size, but still we didn't touch the supraacetabular component, and specifically that there is no collateral damage or internal derangement of the left hip. Mainly, there is no chondrolysis. So I will go. So we booked the patient for the 1 month later. We booked the patient for the second procedure, and in this time we were concentrating on the supraacetabular, which is the periarticular component. And in such cases, that what we have to do is to take care of the joint and of the cartilage. That as we can see here, that we inserted a spinal needle, and then coaxially through this spinal needle we inserted a thermocouple inside the joint, just adjacent to the ablation zone or the presumed ablation zone, with a second needle, with a second intra-articular needle, to achieve active continuous warming by normal saline. What can we achieve? How can we achieve this this technique. So simply that what we need is the hemovalve or the Y connector. We connected on a long spinal needle 18 gauge, and then you can insert coaxially the thermocouple, like it is a flexible thermocouple, and then also we can use the other opening or the other entry opening for the hydrodissection and for constant cooling of the joint. So it is simply what we did is connecting the Y connector to the spinal needle to insert a thermocouple, and then another spinal needle 20 gauge at the junction between the head and neck of the femur, and then just we can inject a normal saline normal saline from the other entry or the other opening. It will get the normal saline or the hydrodissection to the joint, and then get back through the other needle to avoid rupture of the joint capsule. Then we ended the procedure by stabilizing and consolidating the supraacetabular component by injecting, and this time we didn't inject the cement, we injected bone graft substitute to enhance and stimulate the osteocyte and the osteoblast for faster bone formation. 3 months follow-up, the patient she was free of pain, and radiologically what we can get, what we got is significant shrinkage or decompression of the lesion with remaining granulation tissue, and the joint is completely normal with no joint effusion or chondrolysis. And this is the end point in 5 months from the first procedure. What we got is bone remodeling and remetallization of the pubic bone, and specifically of the supraacetabular. What we can see here is the faster new bone formation, and this is the on the MRI what we from 5 months earlier before the procedure, and this is 5 months later. So the message here is that we have to encourage ourselves to go into the tumor board and to discuss such cases and to start getting
We can't hear you, Salim. Are you done? I can't hear you. All right. I'm not sure if you guys can hear me. If someone can just let me know if you can hear or no.
Yeah, we can hear you, Mamoun.
Excellent. Okay. Thank you so much, Dr. Salim, for this interesting case. With this, I think we will conclude our meeting. I would like to thank again, on behalf of the Society of Interventional Radiology in Saudi Arabia, to thank all healthcare workers for working during this tough time. And I would like to thank Dr. Majid Ashur, Dr. Ahmed Haroun, Dr. Yusuf Al-Zahrani, Dr. Nasser Al-Gharim, Dr. Bandar Al-Dhafiri, Dr. Saad Al-Qahtani, Dr. Muhammad Arabi, and Dr. Salim Bayou. And I would like to thank our attendees
we actually reach about 1,800 attendees. So thank you so much. So just to wrap up and to give you like a summary again, it's like 2 hours CME. It's going to be added if your name matches the registration, and there's going to be no certificates. And the recording, hopefully we recorded the session, and we'll try to kind of post it somewhere. You will find it through the website later on. And with that, we will conclude our day. Thank you so much for the successful sessions. Thank you again, all. I appreciate it. Word from you, Dr. Mani. We can't hear you. You're muted.
Okay. Thank you, Dr. Amoun, and thank you, everybody. And inshallah, we'll see you soon in our next webinar. See you. Ramadan Kareem, inshallah.
Thank you. Assalamu alaikum.
As-salam.
Assalamu alaikum.